welcome. I am Dr. Glenn Mitchell. I am the president of our Central Pennsylvania HIMSS chapter, and I'm the vice provost at Harrisburg University in Harrisburg, where I'm also professor of healthcare informatics. Welcome to this webinar today. Today, we are going to speak with Dr. Michael Seavers, who is the program lead and assistant professor of healthcare informatics at Harrisburg University. He is the person who took over from me when I founded that master's degree program. And I'm really happy to have Michael here because of his experience and expertise in the worlds of healthcare finance and policy. Dr. Seavers and I are going to talk a little bit about healthcare and policy and the administrative side, which is really important if you're going to have this be a sustainable methodology. It always takes the kind of policy and legal and financial supports to make it a viable part of any health system. So, Michael, are you ready for a few questions today?
I am ready. Thank you. Thank you, Glenn, and thanks for having me.
Great. Telemedicine was one of those things that we defined in the first part of this, but has the definition of telemedicine changed over the past few years?
As Salim was saying, it has, and you can look at Medicare. Where Medicare really started was dealing with the rural patients and a little bit with behavioral health, and it's really expanded to actually other people in their environments. So it really started in the rural area because at the time about 20% of the rural Medicare patients were in rural America, and only 9% of the doctors were there. So Medicare had some challenges to figure out, okay, how do you get these rural patients in? But then a couple years ago, they actually opened up and they called it virtual checkups. And what that was whenever a Medicare patient went in for maybe surgery, etc., and they needed to do a little bit of checkup after they were discharged from the hospital, instead of coming into the hospital or even a doctor's office, the virtual checkups were also paid for by Medicare. So it definitely has expanded, and obviously from a coronavirus perspective has expanded greatly.
Okay. Well, telemedicine, like any other modality that healthcare providers deliver, has to be in the context of both a legal and regulatory setting and in a financial system. Right now, let's say regarding licensing of practitioners for delivering healthcare over the telemedicine network, most physician licenses, provider licenses are actually done at the state level, and there is no federal license at this point. Is this the right thing to do? I know it's made some problems here and there, or should we be addressing licensure on a different level now that we're experiencing problems in the pandemic and delivering care across state borders?
Actually, that's a great question. To go across state borders has been a challenge. There has been an organization that has caught on, and it's called the Interstate Medical Licensure Compact. And currently, I just looked it up. As of last week, there are 27 states in this compact. And basically what the situation is here is if you are a state, or if you're a doctor in a state that has the doctor has already been licensed, and you try for a license in this other state that's in the compact, you basically have a quick method to get into that state versus everything that you have to go through in another state. The challenge is Pennsylvania isn't in that compact yet. However, if I just looked on their website, and it states that Pennsylvania has interstate medical licensure compact has passed in this state. However, it is delayed right now. Washington, D.C., Kentucky, and Pennsylvania are delayed, but at least they have 27 states, and basically it's a fast pass to get licensing in another state is what this is all about. And it looks like that's the direction that we're going. I looked at the federal level, and in 2015 and then reintroduced in 2017 in the House of Representatives, there was the possibility of having licensures at the federal level, but it hasn't gotten anywhere in Congress at this point in time. So it's still at the state level, and people think that it's just the doctors. No, it's not from a telemedicine, just the doctors. There's a nursing compact that's interstate. There's a physical therapist compact that's interstate, and there's a psychology pact that's interstate. There are different states in these compacts.
So when the coronavirus hit, Governor Wolf here in Pennsylvania lifted the restrictions on state licensing for folks practicing in adjoining states,
Yes.
Which obviously is much different from sort of a federal license. But should this be a new normal? Is this working?
It actually is working, especially for people right on the border. I know some people, even when I was with the Blues, that maybe they lived in Pennsylvania, but their doctor was in Maryland because they trusted the doctor in Maryland better, or vice versa. So this could definitely help out, especially for neighboring states. So I wouldn't be surprised if that is put back into place, meaning that we're going to disregard what we've opened up as we move forward here with telemedicine.
Okay. Well, there are also these parity laws that basically are governing a lot of billing in our states in terms of those people who are legal to deliver care. Could you talk a little bit about the parity laws and what they are, and how that's affecting especially telemedicine?
Well, I'll first start with the definition of parity laws. Basically, there's two camps. The one camp is saying that doctors should be paid the same amount on ground in an office as a telemedicine office visit. And the other argument is that should be a little bit different. So you can well imagine who's on which side here. The payers are on the side saying, you know what, we should be paying less. The reason why we should be paying less is you're not paying rent, you're not paying electricity, you're not paying for the additional equipment that's in each individual office in the doctor's office. That's the one side. The provider side is, well, that might be true, but as Salim was really saying, there's different technology that needs to be done. There's different skill sets. There's different equipment. There's different servers, video equipment, etc. So even though it might be different equipment, we still need equipment, and it should be paid at the same rate. So that's what parity laws are about. Parity means that you should be paying at the same rate between a telemedicine office visit and an on-ground office visit. And one thing that we have, and I need to clarify, is Medicaid. Medicaid in all states is basically adhering to parity, meaning that they're paying at the same rate. Where we're having a challenge is on the commercial side of the fence, that some states have laws in place and some states don't have laws in place. For instance, Pennsylvania, we don't have laws in place when it comes to the consumer side of the fence, but we do have for Medicaid. So the number of states that actually do have parity laws are 36 states. We here in Pennsylvania, we do have the Medicaid. They will pay for the parity situation, but not at the commercial level. So hopefully that explained it a little bit as well. And there's no federal situation from a parity perspective. And the other thing that I need to bring up is with parity, the question is what type of office visit is being paid for? Most of the time video is being paid for. A lot of times audio is being paid for. However, as Salim was bringing up, the store and forward situation, maybe you have some data and you push it to the doctor to look at, or as he was putting it, wearable devices, remote patient monitoring, etc. There's a decent amount of states that are not paying for those type of things. I'll give you an example. Surprisingly, California, you would think would be paying for everything. At this point in time, they are not really paying for remote patient monitoring, even at the Medicaid level. So it's a little bit of a question on what is parity, what should be paid the same, not the same, and actually what should be paid.
Well, Medicare has expanded what will be paid under telemedicine visits recently, but were those increases really consistent with everything else that they pay for ongoing face-to-face visits?
Good question. In looking at all the codes, and when I say codes, we're talking billing codes that would be paid. They basically doubled the number. However, their number wasn't that big to begin with. So even though statistics can say, oh, they doubled the number, they basically went from like 75 to 150 billing codes. What they've added is interesting. Some of the billing codes is for new patients. There's, believe it or not, different billing codes for new patients and for patients that are continuing. So they open it up to billing codes, new patients. They've opened it up to speech, physical therapy a little bit more, so you don't have to go into the doctor's office. Some of the in-home visit situations, they've opened it up to. So yes, Medicare has opened it up, but it isn't everything, at least at this point in time.
So underlying all of this is sort of an assumption that everybody's going to have access to telemedicine and will be able to use this efficient and isolating protective modality to deliver care in this infectious era.
Mm-hmm.
But that there are, as as we mentioned in part one, that there are big areas and in fact large numbers of folks with limited means who don't really have access. The digital divide is what, and I wonder what's been the political situation, and talk about the divide a little, and talk about where we are politically with this conundrum about what to do about folks who don't have access now.
Good question. The digital divide is basically the people who do not have either the technology like a laptop PC to get on the internet, or basically don't have the connection option for the internet. In dealing with Governor Wolf's COVID-19 healthcare inequality subcommittee, we're finding it isn't just in the rural Pennsylvania, it's also some in major urban centers like, urban Philly and things like that, that some people just don't have the money for internet connection. And that's what the digital divide is all about, that some people just don't have internet. I remember working for the Blues that had the opportunity to do a work at home program, so that we sent people out because of their connections, etc. But for some people, we couldn't send out at first because they didn't have the speeds that were needed in their particular areas. And I know Salim was bringing up, some of the outside third-party providers, and maybe healthcare from a policy perspective is we need to team with some of these folks. I know Xfinity is putting some different clumps and areas so that people have internet access that normally don't here in the coronavirus situation. I know that CenturyLink, their niche a little bit is getting access out to some of the rural populations of Pennsylvania, but we need the speeds. You were saying about 5G, but we need the speeds out there in those areas too. Granted, they don't have dial-up anymore, but the speeds need to be there too, especially as we increase our software capability. The speeds need to be there from an internet perspective. So maybe it's time that we do team with these other organizations like Xfinity, Verizon, CenturyLink as well, to get them out there. The other challenge is getting the laptops or even iPhones or whatever out to these populations too. I know the school districts had that particular issue here just very recently. The question is, how do we deal with it also on the medical side of the fence? And it gets to the basic question of this. We as the United States dealt with the Postal Service at one point in time, that we would deliver a letter or package to anyone in the United States. Then we went to rural electric. We said that if you wanted it, everybody in the United States should be able to get electricity. The question now is, from a policy perspective, are we to the point to ask, should everyone in the United States who wants it be able to get internet access? That's really the question at hand, especially with telemedicine, et cetera.
No, and we talk about commercial, the integration of some commercial suppliers inside this. This sort of gets into the whole question of involving third-party payers and insurers, as well as ISPs and and other technological deliverers. We're already getting some health insurance companies that contract with telemedicine companies, so they get a cut rate and they can deliver things cheaper. So their subscribers use the preferred programs. This is a PPO all over again.
Mm-hmm.
Use these preferred programs, cost the insurer less to reimburse if they use these predetermined programs. Is this the right way to lower costs? Is this a good strategy from both the financial as well as the care delivered point of view?
Well, as Liam was saying, obviously he was representing Pinnacle UPMC, and that's from the hospital and doctor conglomerate area. But yeah, the Blues, they have specific preferred vendors that they state. I know MD Live is one that various Blues are using. I think IBC, Independence Blue Cross, down the road from us is using MD Live. A big state like Blue Cross Blue Shield of Texas is using MD Live. So basically the subscriber can pay like $35, $45 for an office visit versus going to maybe their hospital or something like that. With the high deductible plans, it's kind of pushing the subscriber and patient into these like MD Lives, et cetera. And there are two different models for these third-party vendors. The one model is that you have a very limited number of physicians, but they are licensed in almost all states. That's one model. The other model is that they have quite a few providers, but those providers are only licensed in certain states. So it's interesting to see what the models that are growing, but I wouldn't be surprised if insurance companies continue to push their preferred vendor when it comes to telemedicine to try to make it easier. I'm not sure, looking at the crystal ball, who's going to win out here. If you're really going to still stick with your doctor and your in-network provider and hospital, or if the payers are going to push you to a different telemedicine and a whole different model. That one, Glenn, I'm not sure of yet.
Yeah, and those of us who have lived through health information exchange development over these last couple of decades are well aware of the problems of different commercial vendors and different outfits owning different pieces of the patient's record. And how do you feel that's going to come out? Are we going to have more problems again with sharing patient records across physicians and across treatment venues? Is this multiplicity of providers of telemedicine going to just compound the old problem we had of sharing?
Good question. The situation, at least being on the insurance side of the fence, is they believe that they should own the health records of the patient. And their argument was simply this: if you go out of network, well, guess what? Health information exchanges might not be going on in those particular areas. For instance, in Pennsylvania, obviously we have a lot of snowbirds, and they go down to Florida in the winter and they come back here in the summertime. I apologize if you hear a dog in the background. I apologize that right now. But with health information exchanges, that's a little bit tough to get that information. But you're absolutely right. If you go to a third-party vendor, et cetera, who's going to have it? Well, the insurance companies are arguing the fact that, look, we have all the claims data Therefore, we should be the controller. Obviously, hospitals are arguing a little bit differently. And then the patient is saying, hey, I should have complete control of my own personal information. The one positive thing that has come out, and because of coronavirus, it's kind of been pushed down in the media a little bit, are the new blocking rules. Personally, I don't like the term blocking. I think it should be the non-blocking rules, but health information exchanges, hospitals, even health insurance companies now, et cetera, they have to do everything possible to exchange data. This came out from the federal government just here in the last month, these new blocking rules. And the other thing that's interesting is from a patient subscriber perspective, the insurance companies and maybe even the hospitals have to have little gateways into their software so that you can have apps and apps to go in and get the data and bring it out. So it's going to be interesting as we look into the next 2 years how some of the data is being exchanged, especially with these new blocking rules. But to your original question on who owns the data, that's still definitely a debate. The hospitals think they do, the insurance companies think they do, and the patients say, hey, I think we do because it's our data. So very good question.
Yeah. And before I totally drop the issue of billing too, the billing issues in telemedicine have been intense. Over this past couple of decades of experience, I've seen it go from not reimbursable to having multiple layers and dealing with things like, is telemedicine also a telephone call? Because telephone calls have been a billing issue for a very long time. And how do you see the insurers, really the payers, working this out in terms of equity of reimbursement?
Not 100% sure because the phone call situation is definitely a question mark now with telemedicine. Right now, the video side, even with Medicaid, et cetera, that has basically been stated, okay, a video situation will be paid for, especially on the Medicaid level. And now with parity laws, that's getting as well. With just a phone call, that I think is going to get into the legislation on what constitutes a phone call. Obviously, not just a phone call reminding a patient of a scheduled event, but if diagnosis, et cetera, procedure is spoken over the telephone, that is potentially a billable event, especially when you talk about that digital divide again. If they don't have the internet and the video options, audio should be an option for some of these populations of inequality. You're absolutely right. But the question then is, okay, is a video from a parity perspective and an audio the same amount of money? Because you're going to have the insurance company saying, look, you didn't need all the equipment for the video, it should be less. So parity rules are going to come into play again. It seems like video has been dealt with. Audio, you're absolutely right. That's the next area.
Yeah, it certainly is complicated enough. And what I remember you mentioned a little bit ago about wearables and other things on the Internet of Things for remote monitoring, etc. Did you see some real technological innovations having to come to be able to have patients and providers make all of these things match? These are all individual companies and developed sort of separately. Do you see enough standards? Do we need more standards for interoperability and development to actually make the system work correctly?
Well, I think the insurance companies are going to have to really look internally and say, what are we going to pay for and what aren't we going to pay for? But they had to do that with other devices, just even crutches and things like that in the past. That you had to have equipment brought into your house and they paid for it, et cetera. So wearable devices, I think, are going to be the same issue. Over time, they're going to be paid for more and more. The one wearable device I'm still astonished at the healthcare industry doesn't pay for are hearing aids, because of the population that really needs them. I know even for employer groups, they've always asked, well, can we just get hearing aids, but you know, added to the benefit list? But that seems to be a wearable device that I know that doesn't have anything to do with telemedicine, but it's a wearable device that for some reason the health insurance area has really blocked. So I think some of the wearable devices for telemedicine will fall into the same category as hearing aids, unfortunately.
Okay, and that comes very close to home for me, having just gotten hearing aids this year. But the technology is outrageous and growing. I just have to point out that the options available on hearing aids included a switch that when they are listening to someone speaking in Spanish, it will in fact translate and give you the English translation in your ear.
That's just amazing.
When I worked in Central and South America while I was in the service, that would have been a wonderful thing. However, I need the other half of the technology that tells me what to say back in Spanish.
There you go. Yeah.
Which is the challenge. Before I get to ask you your crystal ball question, I just want to ask you, what else should I have asked you?
Maybe on how, as Salim said, it's amazing that the 50 to 60 population is the one that's really honing in on this telemedicine right now. I remember asking the question about 10 years ago in some healthcare classes, healthcare administration classes that I was teaching. And I would ask the students, and they were just older students from, 18 to probably about 50. At that time, like 10 or so years ago, I was witnessing that the younger population wanted to look into telemedicine at the time, and not really the older students. But now it's amazing how things have changed. In talking to some of my neighbors now that are older, they don't want to go to the doctor's office right now. They really don't. They want to stay at home, and they don't want the option or the situation where they might get, another disease by going into the doctor's office. So they are very open to telemedicine. So to Salim's point, telemedicine or coronavirus has been the push for telemedicine right now. And we've advanced probably 10 years, as he was saying, a whole decade that we would probably be sitting here in 2030 right now versus 2020. Of what has happened with the coronavirus.
So you're saying that the situation we have today would have been the answer to the question, where do you see telemedicine 5 to 10 years from now in December? But
Yeah.
now here we are today.
Yeah.
Where do you see telemedicine, and especially from the policy and finance point of view, where do you see it in 5 to 10 years?
You're absolutely right. If you asked me this question in July of 2019, I would have said we would be here in 2030. But to the policy, a couple things have to be dealt with. The parity laws. What do we pay for, and should it be equal? And that's one thing we need to deal with. And that's not only at the state level, that's at the federal level with Medicare. What are they paying for? And their expansion of billing codes needs to progress as well as we need. And the other thing that we have to look at is licensing at the state level for doctors, nurses, physical therapists, etc. Is that really the right thing any longer for the US? Or should there be some type of national situation as we go forward, especially because of telemedicine and the telemedicine push. So those, I think, are the two major players that will be talked about: payment and licensing as we go forward.
Do you think that telemedicine has any chance of contributing to a decrease in healthcare costs, trying to desperately to level our curve of expansion of healthcare costs?
Well, before we talk about the cost, I think there needs to be research to make sure that the quality is still there. Obviously, telemedicine is addressing one of the three major issues in the U.S. healthcare system is access. The cost, we're debating whether it should be the same or not, but the quality side of the fence, I know a person like Salim will definitely say, oh, the quality is absolutely there. But I think we need a little bit more research on that one, because if we can keep the costs down and keep the quality the same, if maybe even better, because it's interesting that he said to diagnose a patient, now he can, or any doctor can look at the actual house and get some variables and indications of some things that are going on. Obviously, you can't get that in an actual doctor's office visit. So my point here is quality is still a little bit out. We don't know that much about it. So to keep the costs down, I think we definitely need to see the quality there.
Well, that really is the hope for our future. We have, we have a sort of pending recession here with this pandemic and what we've needed to do. Truly, healthcare costs have never really been able to be flattened, even in 2008 recession.
Yeah.
So we're hopefully this telemedicine expansion will help us deliver reasonable, at least equal quality care, but at a slightly lower cost. That's the holy grail here for healthcare.
And I apologize, Glenn, the one thing that I didn't talk about, and that's liability issues, legal liability issues. Now with coronavirus, it's being, dealt with. Even Governor Wolf is dealing with, pushing it back a little bit for liability. But the other policy question is going to be from a legal malpractice, et cetera, where are we going with it on the telemedicine side of the fence, especially if some of these devices give bad data back to the hospital or the provider, then who's actually liable in those situations. So it's going to be interesting for the malpractice and the legal side of the fence. So area that we don't like to talk about, but the lawyers will come into play at some point in time too.
Okay, thank you, Michael.